Hello, my name is Jennifer Chan. I'm a medical oncologist and director of the program in neuroendocrine and carcinoid tumors at Dana-Farber Cancer Institute. My talk today will focus on what matters most about systemic treatments. During my talk today, I'll cover a few different topics, including what systemic treatments are and how they work, what factors influence decisions regarding systemic therapy, and I'll discuss the systemic therapies that are currently available to treat neuroendocrine cancers. So starting first with what are systemic treatments? Systemic treatments are drugs that travel throughout the bloodstream to reach cancer cells that are located throughout the entire body. And this is in contrast to local regional therapies such as surgery, ablation, hepatic artery embolization, and histotripsy that are designed to treat local areas of disease. By getting to the entire body, systemic therapies can treat cancers that have spread. They can be administered through several different routes, including by mouth, as injections under the skin or intramuscularly, or given intravenously. There are several benefits of systemic therapy. They can slow disease growth and spread, in other words, slow disease progression. Systemic therapies also can reduce the burden of disease by shrinking cancer, and this can be particularly important if disease is bulky and causing symptoms related to tumor mass. Systemic therapies also can reduce hormone production and secretion of hormone, and this can be particularly helpful if patients are experiencing symptoms related to hormone excess. The ultimate goals of systemic therapy are to improve and maintain patient quality of life and also to extend survival. As we think about what matters most with systemic therapies, there are important factors to keep in mind, and it's also important to recognize that treatment decisions need to be individualized. As we make decisions, we consider tumor-related factors. We also will incorporate patient-related factors, as well as factors that are related to specifics of the treatment. So starting first with tumor-related factors, some of the important factors that are important to keep in mind are the primary tumor location, in other words, where the primary tumor started. Other important things to keep in mind are features of the tumor pathology and biology, and this can include factors including tumor differentiation and grade. We can incorporate findings from radiology imaging to understand the extent of the cancer, in other words, the stage of disease, and we can also identify locations where the cancer has spread. We can learn important information from nuclear medicine imaging with dotatate PET-CT scan to understand whether or not the cancer expresses or has the somatostatin receptor. And finally, we can also understand whether or not the tumor is secreting hormones by understanding whether there are symptoms that patients are experiencing related to hormone excess. So primary tumor location is important, and the reason why it matters is that tumor biology and prognosis vary according to where the primary tumor started. The biology of neuroendocrine tumors that start in the GI tract is different from those starting in the lung and in the pancreas. And stage for stage and grade for grade, the prognosis, for instance, of small intestine neuroendocrine tumors is more favorable compared to lung and pancreas neuroendocrine tumors. The other reason why primary tumor site matters is that treatment sensitivity can also vary according to primary tumor site. For example, some of our treatments that are used to treat neuroendocrine tumors have a higher chance of reducing the tumor size in pancreas neuroendocrine tumors compared to GI neuroendocrine tumors. And also in general, chemotherapy is more active against pancreas neuroendocrine tumors compared to gastrointestinal neuroendocrine tumors. As we think about the pathology of neuroendocrine tumors, it's important to note that there are various categories of neuroendocrine tumors, mainly based on the differentiation or the appearance of the cancer. Well-differentiated neuroendocrine tumors are different than poorly differentiated neuroendocrine carcinomas. They have a very different biology, and we also treat these two categories of neuroendocrine cancers differently. With respect to well-differentiated neuroendocrine tumors, there also are important distinctions based on grade, which are measures of tumor proliferation. Grade 1 disease is lower grade disease, grade 2 is intermediate grade disease, and grade 3, which are more proliferative cancers, are high grade disease. With respect to poorly differentiated neuroendocrine carcinomas, these carcinomas are all high grade by definition. As we look further into features related to tumor grade, again, grade is a measure of tumor cell proliferation that pathologists can see under the microscope on a biopsy by looking at the number of cells that are in the process of division, in other words, the mitotic count. We can also measure grade by looking at the staining for a proliferation marker called Ki67, and the pathologist also can look for features in presence of cell necrosis. As you can see from this table, there are different definitions and categories for grade based on whether a tumor starts in the GI tract or pancreas, or if it starts in the lung or the thymus. But one general and basic principle is that grade, again, measures proliferation and can give us a better sense of what to expect with future growth. Grade 1 disease is slower growing and can spread over a longer period of time compared to grade 3 disease, which is faster growing. The other important thing to keep in mind is that grade is prognostic. Again, lower grade disease grows more slowly and spreads over longer periods of time compared to high grade disease. But the other important thing to keep in mind is that it's important to see how the disease behaves over time. And this is really important because you can gain a lot and understand a lot about the tumor biology by seeing how it grows or it doesn't grow over periods of time. So in the long run, it may be more important to see how the tumors are behaving and growing as compared to relying just on the grade that you see at one single time point on a biopsy. Some of the important features also to keep in mind are patient-related factors that can include age, medical history, and whether patients have other medical conditions that might influence how they tolerate different treatments. Performance status is a way that we measure how patients are impacted by the cancer and how they're able to live with their cancer or how they may be impacted or limited by their cancer. It's also important to consider whether or not patients are experiencing cancer-related symptoms due to the presence or the burden of disease or from hormones that may be secreted by the tumor. One other important thing to keep in mind is that patients may have certain preferences regarding therapy and which agents they might prefer to use and when to use them. Finally, it's important to consider treatment-related factors, and this can include some of the features that I've listed on this slide, including side effects of therapy. They differ from one agent to the other, as does the mode of administration. Again, some agents can be given by mouth, others are given intravenously, or as injections that are intramuscular or under the skin. All of the different treatments vary in terms of the schedule and the frequency of treatment, how available they may be, and the cost in terms of finances as well as time. I'll next go into an overview of the different treatment options for neuroendocrine cancers, starting first with well-differentiated neuroendocrine tumors, where the main categories of treatment include somatostatin analogs, molecularly targeted therapy, chemotherapy, and peptide receptor radionuclide therapy. Poorly differentiated neuroendocrine carcinomas, again, which are different in the biology and different in the treatment from well-differentiated neuroendocrine tumors, are typically treated with chemotherapy, and in some cases, we also will consider immunotherapy. So as we start first with treatments for well-differentiated neuroendocrine tumors, I'll begin by discussing somatostatin analogs. Somatostatin analogs have been a mainstay of treatment for neuroendocrine tumors for decades, and these are drugs that are synthetic versions of the naturally occurring hormone somatostatin. They work by binding to somatostatin receptors that are found on the vast majority of well-differentiated neuroendocrine tumors, particularly those that start in the GI tract and in the pancreas, and also to a lesser degree in the lung. Some of the benefits of somatostatin analogs include that they can improve carcinoid syndrome and other hormonal syndromes by reducing hormone secretion. So, for example, patients who may have carcinoid syndrome can have improvement in symptoms of flushing and diarrhea through use of somatostatin analogs. We've also seen from several clinical trials that somatostatin analogs can slow growth in GI and pancreatic neuroendocrine tumors. There is also data that they may slow growth in lung neuroendocrine tumors as well. Somatostatin analogs are given as injections, either intramuscularly in the case of octreotide or as a deep subcutaneous injection in the case of lanreotide every 4 weeks. We can sometimes shorten the duration in between injections if patients have symptoms that begin to return after a 2 or 3 week time point. And sometimes we also may consider increasing the dose of somatostatin analogs because there is some data that higher doses may be able to slow disease growth. Some of the side effects of somatostatin analogs include diarrhea, GI upset, high blood glucose levels, gallstones, and pancreatic exocrine insufficiency, which is usually manifested by loose and greasy or oily stools. I will say that somatostatin analogs are generally well tolerated, and this is one of the reasons why they also are often used as a first-line therapy. The next category of treatments that we use for neuroendocrine tumors include molecularly targeted agents. And this class of medication works by blocking signaling pathways in cells that are responsible for survival of cells, growth, as well as formation of blood vessels. The main categories of agents that we use in this class include tyrosine kinase inhibitors. The way that these classes of medications work is that they can inhibit receptors that are found on the surface of the cancer cells that can signal for the formation of blood vessels and cell growth and spread. The other class of medications that we use are mTOR inhibitors, which can block the mTOR signaling pathway that also can lead to cell growth as well as changes in cell metabolism. Everolimus is an example of an mTOR inhibitor that is used to treat neuroendocrine tumors. And the benefits of everolimus is that it can slow disease progression, in other words, slow the process of growth and spread to new areas in pancreas neuroendocrine tumors, as well as in non-functional GI and lung neuroendocrine tumors that are not associated with a hormone syndrome. Everolimus is taken by mouth as pills daily. Some of the side effects of everolimus include fatigue, mouth sores, skin rash, high blood glucose levels, decreased appetite, diarrhea, lung inflammation, or what we call pneumonitis, swelling in the extremities, and changes in taste. It's important to recognize that these side effects may occur, and if they occur, it's important to know that doses can be modified to make treatment more tolerable. Cabozantinib is also a molecularly targeted agent. It's an example of a tyrosine kinase inhibitor that works by blocking multiple receptors that are found on the cancer cell surface, including the vascular endothelial growth factor receptor and the receptors called MET, AXL, and RET. These receptors are responsible for blood vessel formation as well as tumor growth and spread. Cabozantinib is one of the newly approved agents for treatment of neuroendocrine tumors and was approved by the FDA in March 2025 for the treatment of patients with pancreatic neuroendocrine tumors as well as extrapancreatic neuroendocrine tumors. And the extrapancreatic neuroendocrine tumors are tumors that originate in organs outside of the pancreas, most commonly in the GI tract, lung, also unknown primary sites and rare primary sites like the thymus. Cabozantinib can slow disease progression and also in some cases can lead to tumor shrinkage, particularly in patients with pancreas neuroendocrine tumors. Cabozantinib is also a tablet that can be taken daily by mouth. Some of the side effects that can occur with cabozantinib include fatigue, diarrhea, high blood pressure. There can be development of swelling and redness and discomfort in the palms and the soles, mouth sores, decreased appetite and weight loss, as well as changes in taste. And again, it's important to recognize and to watch for these side effects because if they do occur, treatment doses can be modified to help make treatment more tolerable and to maintain quality of life on therapy. Sunitinib is another example of a tyrosine kinase inhibitor. Like cabozantinib, although it blocks different receptors from cabozantinib, it has been shown to slow disease progression and is approved to treat pancreas neuroendocrine tumors. Sunitinib, like everolimus and cabozantinib, is taken daily by mouth. Some of the side effects of sunitinib are similar to those seen with cabozantinib and listed here on this slide. Cytotoxic chemotherapy is another broad class of treatment used to treat neuroendocrine cancers and other cancers. They work by killing cancer cells through interfering with DNA replication and cell division. Chemotherapy with alkylating agents, including streptozocin or temozolomide, can be effective for treating pancreatic neuroendocrine tumors. One commonly used chemotherapy regimen for pancreas neuroendocrine tumors is the combination of capecitabine and temozolomide, or CAP-TEM. And this is an oral chemotherapy regimen that can slow disease progression in pancreatic neuroendocrine tumors and also can lead to shrinkage in many cases. More commonly, we do not use cytotoxic chemotherapy for small intestine neuroendocrine tumors, while it is routinely used to treat pancreatic neuroendocrine tumors and also lung neuroendocrine tumors. Some of the common side effects that can occur with cytotoxic chemotherapy include fatigue, nausea, vomiting, mouth sores, diarrhea, a weakened immune system, low blood counts, as well as discomfort and redness in the palms and the soles. Peptide receptor radionuclide therapy, which you'll hear about in several other talks, is a class of medication that consists of a somatostatin analog that's linked to a radioactive radionuclide. The way that these agents work is that they bind to the somatostatin receptors on neuroendocrine tumor cells. They're taken up into the cell. They release the radiation internally to cause tumor cell death. Lutetium-177 dotatate is an example of PRRT, and it has been approved for the treatment of somatostatin receptor positive gastrointestinal and pancreatic neuroendocrine tumors. Some of the benefits of lutetium-177 dotatate is that it can slow disease progression. It can also lead to tumor shrinkage, particularly if it's higher grade disease or if the tumor originates in the pancreas. And lutetium-177 dotatate can also improve symptoms that are related to hormone secretion by disease. Some of the side effects of peptide receptor radionuclide therapy include fatigue, nausea, GI side effects, and there is also a need to use amino acids to protect the kidneys. And there's a small but real risk of myelodysplasia and leukemia that needs to be monitored for. This slide is a summary of all of the agents and the categories of treatment that I just reviewed. I won't go into detail since we reviewed this information already, but I just wanted to point out that it is important to keep in mind some of the factors that we discussed, including primary tumor location, somatostatin receptor presence as we make decisions regarding treatment. There also are some differences in the treatment outcome between these various classes of medication. For example, with peptide receptor radionuclide therapy and chemotherapy, there's a higher chance of shrinkage. So these categories of therapy may be more important for patients who have high burden of disease and symptoms where shrinkage can be important. The way that these treatments also vary is in terms of their side effects. So again, it's important to consider and monitor for side effects. And also as we make decisions regarding selection of treatment, we have to consider patients and their underlying medical conditions because certain agents may be more tolerated and better for some patients compared to other classes of medicines. So again, as we think about the various categories of treatment and the systemic treatment options that are available for well-differentiated neuroendocrine tumors, there are important points that I wanted to make. One, again, is that treatment selection must be individualized and really needs to be made with multidisciplinary input. As we think about sequencing of therapy, this is a very complicated topic and again needs to be individualized, but somatostatin analogs are very often used in the first-line setting, given their effectiveness as well as the fact that they are well tolerated. In some cases, for example, patients who may have high disease burden or who might have higher grade neuroendocrine tumors, we can consider alternative first-line treatment choices such as PRRT or chemotherapy before or even in conjunction with somatostatin analogs. One approach is to select one therapy, and if there is disease progression, meaning growth or spread, we'll switch to another agent. The other important point to make is that there has been a lot of progress in recent years in the treatment of neuroendocrine tumors, and clinical trials are an important way that we investigate and find newer agents. So if there are clinical trials that are available, this should be discussed with your treatment team. Next, turning to poorly differentiated neuroendocrine carcinomas, these are different and more aggressive cancers than well-differentiated neuroendocrine tumors. They are not usually associated with hormone syndromes, although in some cases they can be. As mentioned before, treatment is very different for poorly differentiated neuroendocrine carcinomas compared to well-differentiated neuroendocrine tumors. For the poorly differentiated neuroendocrine carcinomas, we typically will treat with chemotherapy with agents such as cisplatin or carboplatin with etoposide. Immunotherapy also may have a role in the treatment of neuroendocrine tumors, and there are clinical trials that are ongoing to investigate this. So for take-home points, the first point that I've mentioned before and will say again is that treatment decisions need to be individualized and made with multidisciplinary input. There are multiple treatment options that are available, and we need to consider both patient-related, tumor-related, as well as treatment-related factors as we make decisions regarding therapy. And I do want to end on a high note that progress continues to be made in the treatment of patients for neuroendocrine cancers. We have an expanding number of treatment options that are available, and it is our hope that with this progress that we will extend survival and continue to improve quality of life for our patients. Thank you.